So, I couldn't wait. I put a poll up yesterday asking you what you wanted to learn next, and ankle ligaments became the #1 leader. Early leader. It's a 7-day poll, so get yourself on there. And I'm expecting people to add a few things in as well. So here we've got the lateral ligament complex, we've got ATFL and we've got CFL, the two most commonly injured ankle ligaments, I would argue. Yeah. So first thing is getting people to understand where they are when you don't have a skeleton. Put yourself in 90 degrees dorsiflexion. Draw a line from the tip of the lateral malleolus straight forwards, and that's pretty much where the ligament goes, so that when the foot actually gets plantar flexed, you've got this nice ligament that sits there. So that's a great way of identifying the ligament. However, if you've got a patient who's got a painful ligament when you dorsiflex and internally rotate the foot, then obviously you're going to find out where that painful bit is. Most of the time, its origin from the lateral malleolus, so this fibula there. And if you were to take your radial device and start to try and treat those ligaments, your patient goes straight through the roof like a firework. It's not going to work. Now, I have shown you tender areas where you actually build up quite a height of the gel over that area, and then you could be almost like creating a focus level standoff, and you gradually work your way closer and closer. But this just isn't going to get you any kind of result because it's just too painful in that area. Now, if we were to look at those of you that have got the EMTT, that fits nicely over the ankle. Now, the greatest energy, I believe, is at the edge here, and so you want to really try and get that person so that the EMTT is sitting right across that part of the ankle there. I don't know how well you're seeing that on the video, but you want the EMTT to be really just cupping that distal end of the fibula, that lateral malleolus, and you want to be sitting tight onto there. So however you position your patient, I tend to have the patient face down, so lying in prone, and we slot the EMT just over the ankle that way, and then we can cup it nice and tight against that lateral malleolus. Now, when you have the focus device, all of a sudden we've got a great deal of options. So a nice big blob of gel. Obviously we're going to use the bigger standoff because it's so superficial, and we can work directly onto, and let's really try and get that in there, we can work directly onto that ATFL straight there, no problem. CFL as well, we can go straight onto there. Now, how we're going to do that really determines the extent. Whoa, we fell off. Really, it turns, determined by the extent of the injury and the stage of the injury. Now, if they're particularly acute in their injury, i.e. it's happened within the last day or so, then you're going to want to think seriously about using some very, very low energy. Whoa, we're really struggling to keep the camera going today. You're going to want to think about using some very, very low energy, 0.03 on the energy flux density, just to start to engage with those cells and start to develop a little bit of healing. Now, we know that in the early stages, Shockwave can be pro-inflammatory, but ultimately is anti-inflammatory. So then where do we sit with this whole ice in terms of reducing inflammation? I'm not a fan of ice. Maybe in the very, very, very acute stage of the ankle injury, ice might be helpful as a pain reliever, but I much prefer the movement, exercise, analgesia and treatment, the MEAT principle. And I think little and often, relatively as pain-free as you can movement, and doing some treatment, low level with the focus device there, really speeds up the rate of that injury. And I think we can tap into those acute mechanisms. So I think you can get stuck in straight away on an acute level with your focus device. But particularly if you're a little bit worried about doing that, and don't take my word for it, then definitely come in with the EMTT. I mean, that is next level. That reduces the pain, gets them moving, and a good taping strategy around the ankle to make it feel supported and just look after those ligaments. Now remember, we've got some upregulation and deregulation of things like tibialis posterior and peroneal longus. We want to factor that into our taping structures to make sure that we're looking after, if you like, the reins of that foot, because we've got these muscles that kind of work simultaneous together but also can work against each other. And if you've got a little bit of down regulation from one and up regulation from another, that can start to give you a disparity in where the person walks and a difficulty in terms of the healing mechanism long term, even hip pain, knee pain as a result. So we can get in with the EMTT early, and we can start to stimulate those fibers with the focus device early. We can kind of slide past all of those issues really deftly, and we can get the person back doing what they want much, much quicker than if they don't have intervention. Now, where's the science for me to support that? I don't have a tremendous amount of science to support that, but I've got a ton of anecdotal evidence, and whether you love that or hate it, and you can call me out for using anecdotal stuff, sometimes science needs to catch up, and I'm a great advocate of using EMTT and focus shockwave. But if all you've got is focus shockwave, then use that. I think you're going to struggle with radial on its own, so invest in the kit that works on the conditions that you're going to see. But a very, very good, I mean from day one, treatment strategy for an acute ATFL and or CFL ligament damage. I think this equipment is next level in terms of what we can do. If you're coming to it as a bit more chronic, you can start to lift those numbers up. And because we've got a teno-osseous junction, the tendon and the bone, I think you really need to be working away at the 0.25, if you can, on that lateral malleolus. And I think even if you start at the acute setting and you're 0.03, you still want to be working up towards 2-3 weeks in, you want to be working at that 0.25, which your patient will let you get to eventually with that focus device, because we've got to work at the attachment of the bone. So we need to be working on that bone damage that's happened there as well. So I hope that's really helpful. Most of you like really tight protocols. So 1500 shocks as a standard. You can go from 0.03 when it's very acute up to just as it's starting to really in the latter stages of healing, or if it's quite chronic, you want to be up to 0.25 on the lateral malleolus. You can still be down at 0.1, 0.15 on the actual ligament itself. And I think you can treat these a couple of times a week, no problem. And you could be north of 8 to 10 sessions on this. Don't just stick to your 3 sessions of 1500. We've got to work a bit more on these ligaments. Hope that's helpful. Hope that answers your question. If you disagree with me, that's where to put it, in those comments. And keep going with the poll, please. That would be really great. Now, last little thing. Anyone in Phoenix from next week, please get in touch. We're going to have a great conference there with the Institute of Tissue Regeneration and Repair and Curomedics. Really looking forward to it. And if anybody is keen to go to the Phoenix versus Timberwolves game on the Friday night, hit me up. Basketball forever, dudes. Thank you.